Hey, everybody. It's my pleasure to introduce Dr. Sarah Wakeman for her talk on treating opioid use disorder. Sarah is the medical director of the Substance Use Disorder Initiative in the Department of Medicine at MGH, and she's an assistant professor at Harvard Medical School. I think for many of us who've had the opportunity to learn from Sarah, she's really changed the way many of her trainees, the way I, and hopefully now many of you think about substance use disorder. So I am certain that you will enjoy this talk.
Thank you so much for that kind introduction. Thanks everyone for joining this morning, and I'll get started. In terms of disclosures, I'm a scientific advisor for Celero Systems, which is looking at novel interventions to address overdose. I've done research with Optum Labs, which I'll talk a little bit about today, and I'm a reviewer for UpToDate. So we are in the midst of a public health crisis, arguably 3 public health crises now that are ongoing. The drug overdose crisis, of course, COVID-19 pandemic, and racism, which has been with us for more than 400 years, but has recently led to ongoing recognition of the toll on health of living in a racist society. When we think about the ongoing health crisis of drug overdose deaths, the reason we talk about this as a public health crisis is really the toll of what's been going on. There are now more people that die each year from drug overdose than the peak number of deaths from car accidents, from firearms, and from HIV at the height of the HIV epidemic. Although we saw a brief dip in deaths in 2018, we saw an increase, unfortunately, last year, and are anticipated to see an even higher increase in 2020. The toll has been so dramatic, in fact, we've seen U.S. life expectancy decrease for 3 years in a row, which is the first time we've seen that since the influenza pandemic of 1918. In the context of COVID, unfortunately, we are seeing additional harms to people who use drugs and people with substance use disorder, with overdose surges identified in many counties, and nationally with suspected overdoses up 42% per month during the pandemic compared to the same months in 2019. When we think about the current crisis and our response and how we can intervene as healthcare providers, a lot of the attention has focused on opioid prescribing. Many of you, I'm sure, are very familiar with the common narrative around prescribing, and there's been a lot of changes to prescribing through legislation, through guidelines, and even through legal action. And that's really because when you look at the onset of the current overdose crisis, it was strongly correlated with changes in opioid prescribing, with rising rates of opioid pain reliever prescriptions correlating with rising rates of death due to opioid pain relievers and treatment admissions for opioid use disorder. And yet we've seen, because of this increased attention, legislation, regulations, guidelines, importantly, we've seen prescribing rates decrease every year since 2012. And the message has certainly been had that the prescribing practices of the late 1990s are really not concordant with what we know from the best evidence for managing chronic pain and acute pain in 2020. And yet, if all it took to address the overdose crisis was to change our prescribing habits, then you would think that we would have declared victory starting in 2012, or at least would have seen a decrease in deaths due to opioids. And yet what we've seen instead is actually an increase in overall death and an uptick in the rapidity of death. And that's really because I would argue that when we think about drug crises and overdose crises in particular, it's not about the supply side of the equation, or certainly not just about the supply side of the equation, but really the demand side of the equation. And if all you do is make it harder to access prescription opioids, people using opioids are not going to magically stop using opioids. What's going to happen is they shift into the illicit drug market and the illicit drug supply, which is unpredictable, unregulated, and increasingly poisoned with illicitly manufactured fentanyl. And so what we saw was that as there were changes to access to prescription opioids, there was a transition to an increase in heroin use and heroin-related overdoses. And then beginning in 2015, this dramatic increase in illicitly manufactured fentanyl-related overdoses, and that's really been driving the ongoing death toll. So when we think about responses, I think focusing just on prescribing is problematic, in part because the focus on prescribing has not led to a change in or an improvement in overdose deaths. In fact, we've seen an increase in overdose deaths and this, again, transition into illicit opioid use. But also we know that blunt policies to restrict opioids may be problematic. So this was a study that shows, again, that there's been a consistent decrease in the prescription of opioids over the past many years. And you would think that if we're trying to minimize the use of prescription prescription opioids where unnecessary. The group that we would hope to see the biggest decrease would be in people who really don't need opioids. So those with less severe pain, where pain could be successfully managed with non-opioid interventions. And yet what we actually see is that the greatest decreases have been amongst adults with moderate to severe pain. So not exactly where we would think. But importantly, there's huge disparities in how these policies get implemented and the impact of racism and other biases in our prescribing patterns, which have been there all along, and how these changes in regulations might cause disproportionate harm. And we've seen that the largest reduction in opioid prescribing occurred amongst Black adults and people with incomes below the poverty level. Racism has been hugely impactful in pain management. Unfortunately, some people have made the misstatement of saying that racism has, quote unquote, protected Black people from the overdose crisis. I think it's important to note that racism is never protective, that racism has led to undertreated pain in Black and Latinx communities and continues to lead to disparities in access to treatment for addiction. This was a really disturbing study showing that racism dramatically impacts pain management. This is a study of 222 white medical students and residents that found that 50% endorsed one or more false beliefs about biological differences between Black and whites, including such false beliefs that Black people's skin is thicker or their nerve endings are less sensitive. Really, I think, deeply disturbing that 50% of students and residents believe that. And those who endorse these false beliefs rated Black patients as feeling less pain. We also see racism playing out in the overdose crisis. The public narrative, both within the medical community and in the lay press and media, has predominantly focused on the impact of the overdose crisis on non-Hispanic white people. And yet the overdose crisis continues amongst the non-Hispanic Black population, with an increase of deaths due to illicitly manufactured fentanyl of 818%. Across all communities, fentanyl is driving the death toll. And in some states, the rate of opioid overdose death amongst Black Americans actually exceeds the general population and the white population. And yet our historical approach to communities, when the perception has been that Black or Latinx people are suffering from a drug crisis, has been one of crime and punishment, of mass incarceration, the war on drugs, in contrast to this current sort of gentler narrative of a public health crisis, when the perception has been that this is impacting predominantly white people. The other reason why prescription-only interventions are problematic is that actually there's a growing body of evidence that has raised some concern that overdose death may be more common after the discontinuation of chronic opioids. So if the intent of us changing our prescribing practices is to keep people from dying from overdose, at least physician-initiated discontinuation, meaning not a patient engaging in shared decision-making around discontinuing opioids, but a physician saying, I'm no longer going to prescribe these high-dose opioids to you because of new guidelines, that actually there's an increased risk of overdose fatality after that and a fracturing of the doctor-patient relationship. So it's just not as simple as prescribe less. We have to think bigger about how to address the overdose crisis. And one key component of that is how to actually treat opioid use disorder. The shifting patterns and shifting harms have been known for many years now. So this is a paper in the New England Journal in 2015 that showed that as access to prescription opioids and changes in formulation, like the reformulation of extended release oxycodone happened, that again, similar to the national data, rather than seeing lives saved, we simply saw more people dying from heroin. And that gets to the nuances of these supply and demand drivers of the overdose crisis. So there are supply side drivers. Excessive opioid prescribing was a supply side driver of the current crisis, as were changes in the drug supply with highly refined Mexican sourced heroin, and then subsequently synthetic opioids adulterating the supply. And then there are the demand side drivers. Initially, demand for prescription opioids partially drove demand for heroin, and demand for heroin has fed the demand for fentanyl as substitute. But when we think about what it is that's driving the death toll, it's really this contaminated drug supply. It's the poisoning of the drug supply with illicitly manufactured fentanyl. And paradoxically, focusing on supply can actually cause unintended harms, which is the so-called iron law prohibition that we saw with alcohol prohibition, where when individuals are going to take the risk to manufacture, distribute, or other people to actually buy or purchase or use a now criminalized substance like alcohol, it was much, the return on investment was much higher to use a potent substance like spirits. So we saw this transition in American use patterns from beer and wine, lower alcohol content substances, to high alcohol content substances with spirits. And we're seeing a similar thing in the illicit drug supply with this transition to illicitly manufactured fentanyl. We have heard historically this sort of catchphrase that addiction doesn't discriminate. I would argue that's probably not true. We know that there's a strong correlation between adverse childhood experiences and the development of a substance use disorder, and that people who are already facing adversity are more at risk of developing addiction. But we know for sure that overdose does discriminate, that people who are most likely to die from overdose, particularly in Massachusetts, where we have great data on this, but also nationally, are those who are already at risk of other vulnerabilities and are already deeply marginalized in our society. So for example, people experiencing incarceration and people experiencing homelessness have the highest rates of overdose death, markedly higher than the general population. And this is particularly important because treatment models are not designed with these populations in mind. And in fact, our most marginalized patients are often least able to access treatment and least able to stay in treatment. So when we think about what does work to address overdose, I think it's important to note that much of what has driven our addiction treatment system, its structure, our drug policy in this country has been based on stereotype, or in the case of drug policy, really on racism. And this is a quote from Dr. Dole, who's the physician scientist who discovered methadone as a treatment for opioid use disorder. And he reflected back on his career on sort of stumbling into addiction medicine and coming into it the same biases that I think many of us have coming up in American society towards people who use drugs, with this image of a person who uses drugs as being someone who's weak, who's pleasure-seeking, unreliable, dangerous, and that's entirely false. And yet this myth continues to be believed by much of the medical profession and the general public and distorts our public policy and our treatment approaches. Think of, in fact, if we instead step back and think, what does science show us are effective interventions? We have a huge body of research and evidence showing us what are effective treatments for opioid use disorder in particular, both in terms of improving remission rates and reducing the likelihood of death. And so the gap here really is in translating what we know from science into actual clinical practice, where there continues to be a chasm. So I'm going to stop here for a question before we move into the data. So when we think about opioid use disorder, what is the only treatment for opioid use disorder which has been shown to reduce overdose? A, long-term residential treatment, B, oral naltrexone, C, intramuscular naltrexone, D, buprenorphine or methadone, E, 12-step mutual support. So I'll let you guys vote now. Thanks for voting, people. Great to see that come through. We'll give it another minute. We've got almost half of people voting, so that's fabulous. Okay. So the majority of you got this, although there was a spread, but the only treatment that's been shown to reduce overdose is buprenorphine or methadone. So buprenorphine and methadone are both opioid agonists. So when we think about medication treatment for opioid use disorder, and we'll talk about this in more detail, we tend to think of agonist therapy versus antagonist therapy. And methadone and buprenorphine are life-saving medications. They've been shown time and again in observational and in randomized clinical trials to reduce mortality, both all-cause mortality and overdose-specific mortality. The life-saving potential of these medications is so dramatic, they've been added to the World Health Organization's list of essential meds alongside things like HIV medication. And this is one of many studies. This is a large meta-analysis looking at the risk of mortality, both all-cause and overdose specific, when people are engaged in treatment or out of treatment for methadone and buprenorphine. And you can see that all-cause mortality is reduced by about threefold when people are engaged in treatment. This is a study that I did with colleagues using Optum claims data, comparing 6 different treatment pathways for people with opioid use disorder. So no treatment to intensive behavioral treatment, to standard behavioral treatment, to inpatient residential treatment, or medication treatment with methadone or buprenorphine or with naltrexone. And what you can see here is that the only treatment that was shown to reduce overdose, both at 90 days and at 180 days, was methadone buprenorphine. And that the other types of treatment, you can see this is inpatient detox or residential treatment, which I think many people still think in their mind as being sort of the best treatment for addiction. That's the yellow line there. Actually, it was no better than no treatment when it comes to preventing overdose. So the data is quite clear that if our goal is to keep people alive, keep people from overdosing, the best treatment we have is methadone or buprenorphine. And this has been shown across countrywide observational data as well. This is the country of France, where when they are in the midst of their own heroin epidemic, you can see in the black line the peak of heroin overdose deaths. They rapidly expanded access to buprenorphine. And unlike our country, where we have tightly regulated access to these therapies and made it actually quite hard for patients to access them and for providers to provide them, in France, there's no required physician training. There are no patient limits. There's no toxicology or counseling requirements. And they were able to get about 90,000 patients treated with buprenorphine and 10,000 with methadone. They saw a 5-fold reduction in heroin overdose deaths, a 6-fold reduction in active injection drug use, and a decrease in the HIV prevalence amongst people who inject drugs. So really dramatic impact at the community level of expanding access to these life-saving treatments. And I think it's important to really note that we have good data on this, and not all treatment pathways are equally effective. We often give lip service to this idea of sort of multiple pathways to treatment. And it's not that patients shouldn't, of course, have choice and autonomy in deciding what is the right treatment for them, but they need to be informed, just like with any other care. If we think about cancer care, diabetes care, we make sure we think about informed consent, that patients and family members truly understand the likelihood of outcomes with different types of treatment. And yet we don't do that with opioid use disorder. This was a small randomized controlled trial published in The Lancet, looking at people in an inpatient detox setting who had heroin addiction, and randomizing them to either buprenorphine maintenance treatment for a year or to detox, meaning tapering doses of medication and then intensive counseling for a year. That showed that in the group that went to detox and got intensive counseling for a year, no one stayed in treatment. 100% of people had recurrence of opioid use, and 20% were dead at the end of 1 year. In contrast, in the buprenorphine arm, 75% were retained, 75% were abstinent, and no one died. So really dramatic differences. And I think if we had another treatment that led to no one getting well and 20% of people dying at the end of 1 year, we would not continue to offer it. And we certainly wouldn't continue to suggest that it's as effective as other superior treatments. The other thing that's important to note is that this is a good prognosis disease. And I think that message of hope is not one that we usually feel when we hear about someone who's injecting fentanyl or injecting heroin. And yet most people with effective treatment will get well. And that is an inspiring and important thing to remember. Going into this field, treating opioid use disorder is the most rewarding thing I do in medical care. I also do general medicine. I do primary care. I work in the hospital. And the single most rewarding thing I do in clinical practice is prescribe opioid agonist therapy for people with opioid use disorder. Most people will get better. This is a long-term study of patients with prescription opioid use disorder who are treated with buprenorphine, and at the end of 42 months, only 8% still met criteria for, at that point, DSM-4 diagnosis of opioid dependence. So 92% of people were in remission. That is dramatic. We don't see those numbers with other types of health conditions. And so all of this data, and I've shown you just a smattering, has led to this really important report by the National Academy of Science, Engineering, and Medicine last year, Medications for Opioid Use Disorder Save Lives. It's a wonderful reference for those who are interested in more detail, and it also has some high-level summaries. And it led them to the conclusion that medication treatment for opioid use disorder is effective across all treatment settings, and that withholding or failing to make available all types of medication treatment in any care setting, meaning hospital, emergency room, primary care setting, addiction treatment setting, or criminal justice setting, is denying appropriate medical treatment. Denying appropriate medical treatment. So for those of you who are listening, I hope that you work in a setting that offers buprenorphine and offers direct referral to methadone and offers naltrexone. And if you don't, I think now's the time to really think about, how do we meet this standard of care? So how do you actually treat opioid use disorder? It's one thing to think about the high-level evidence, but how do you translate that into clinical practice? Well, much like for any condition, you first have to identify and make a diagnosis of the condition, and a diagnosis for opioid use disorder is made with a DSM-5. An opioid use disorder is a problematic pattern of opioid use leading to impairment or distress manifested by at least 2 of the below symptoms occurring within a 12-month period. Importantly, opioid use disorder cannot be made based on the diagnosis of tolerance and withdrawal alone, as those 2 components will be present for anyone who takes daily chronic opioids, be it for pain or for patients on chronic opioid agonist therapy as a treatment for opioid use disorder. We base the diagnosis, or we rate the diagnosis as mild, moderate, or severe, depending on the number of symptoms someone may meet. So 2 to 3 would be a mild opioid use disorder, 4 to 5 would be moderate, and 6 or more would be severe. When we think about effective treatment, I think of kind of 4 main components. The cornerstone of treatment for opioid use disorder is medication, as I've already emphasized, and I'll talk through the details of that more. But there are other components, just like with any other management of a complex disease, that should be available and are incredibly important. Psychosocial interventions like cognitive behavioral therapy, motivational enhancement therapy, contingency management are all manual-based, evidence-based psychosocial interventions that should be available, although not required, for people who are treated with medications for opioid use disorder. Recovery supports are things like recovery coaching, mutual help organizations in the community, recovery support centers. These are not formal treatment, but can be invaluable for people as they navigate their way through treatment, staying engaged in treatment and building their lives. And then harm reduction has to be a component of treatment. So reducing the negative consequences of use, including overdose education and prevention, naloxone distribution, safer injection, equipment, and education are all crucial components. So this is very similar to the management of diabetes or HIV. There's no cure. Our goal really is to prevent the acute and chronic complications of ongoing illness. And we have to individualize that treatment to the human being in front of us. So if we think about diabetes care, I may think it's really important for someone to start insulin based on what their A1C is. But if they tell me they're terrified of needles, I'm not going to not offer them metformin or oral therapy. I would really talk to the person and create a patient-centered plan while informing them of the risks and benefits of different types of treatment. And yet too often with addiction, we tend to make it this black or white thing. And if patients don't want to follow every single idea that we as the care provider have, then we blame them. We say they're not motivated, they're not ready. That is not patient-centered care. That is provider-centered care, treatment-centered care, program-centered care. And so that shift is crucial when we think about effective opioid use disorder treatment. When you think about the medication component in particular, there's 4 main goals. The first primary goal is to relieve the suffering of withdrawal. If we don't adequately treat withdrawal, people are never going to make it to the next phases of treatment, but only treating withdrawal, which is what detox is, does not lead to successful outcomes. So the first step is relieve withdrawal with methadone or buprenorphine, and then engage people in long-term medication treatment to block the effects of other opioids, to reduce cravings, and to, over time, help restore the normal reward pathway and their quality of life and their functional status as our important end goals. In terms of details of treatment, agonist therapy consists of either daily methadone or buprenorphine. The goal is really a stable level of opioid effects. So think of long-acting insulin. The idea is that someone is neither intoxicated nor in withdrawal, but they just feel normal. Unfortunately, in this country, we tightly regulate these therapies, which reduces access. And so buprenorphine requires a waivered prescriber, or methadone has to be dispensed out of an opioid treatment program. And again, that is pretty unique to the United States. The goal of treatment is to reduce or stop entirely the ongoing opioid use and the risks that go along that. And the reason we care is because we hope that people's psychological and physical health, their quality of life, and their functional status will improve. Antagonist treatment, naltrexone, consists of a once-monthly injection, and anyone can prescribe it. Okay, so one more question. What is an effective dose of methadone to suppress opioid cravings? 10 to 20 milligrams, 30 to 40, 40 to 60, or 60 to 120? Go ahead and vote, please. Okay, we're seeing a pretty split group here over all the different dose categories. So great to talk about this. So 60 to 120 milligrams when we think about suppressing craving. So withdrawal symptoms generally can be suppressed at 30 to 40 milligrams. Although in the era of fentanyl, I feel like sometimes people are needing higher doses, but in general, 30 to 40 will manage acute withdrawal symptoms. But for craving, we have to get to a much higher dose. So what about dosing? So when you think about the details of treatment, so methadone, again, withdrawal management, usually 40 milligrams or so. But every study looking at craving and suppression of ongoing use has shown that you generally have to get higher than 60 milligrams per day, and that higher doses are more effective both at treatment retention and reduction in ongoing opioid use. For buprenorphine, higher retention has also been shown with higher doses. So 16 milligrams or higher has been shown to correlate to higher retention and higher abstinence rates. And at higher doses, buprenorphine is likely as effective as methadone. Naltrexone is dosed in a once-a-month intramuscular injection for opioid use disorder at 380 milligrams a month. Oral naltrexone has never been shown to be helpful for opioid use disorder because of poor adherence. So in terms of choice of medication, the most important choice is the medication that the patient will take. So like any other treatment, medications only work if patients take them. So patient preference and their prior experiences are crucial. And for some people, the structure of an opioid treatment program and the way methadone is dispensed can be helpful. That sort of daily check-in can be a useful facilitator of engagement. For many others, it serves as a barrier. I won't read through this quote, but this was a qualitative study with a patient saying, they really felt like methadone would be a better treatment for them, but they were not willing to go to a clinic every single day given their job and their life. And so they were taking buprenorphine instead. Naltrexone, the studies have shown that it's less effective than opioid agonist therapy for all comers with opioid use disorder. But for a subgroup of patients who are able to complete medically supervised withdrawal who want naltrexone despite being offered methadone or buprenorphine and who are able to start it, it seems to be non-inferior to buprenorphine. And then there are special circumstances. So patients with severe co-occurring pain, historically we've thought about methadone as being the best option for them, although there's growing experience with buprenorphine for pain. In the context of pregnancy, buprenorphine seems to be associated with better baby outcomes and methadone with better retention for mom in treatment. And then patients who have a prolonged QTC at baseline, we're usually thinking about buprenorphine. Importantly, buprenorphine is effective with or without adjunctive behavioral treatments. This has been shown in a number of randomized clinical trials. This was one by Walter Ling showing no benefit of adjunctive CBT, contingency management, or both compared to medication management alone. That doesn't mean counseling shouldn't be available to patients, but patients should not have medication denied because they're not interested in psychosocial interventions. And in fact, NASM added this to their consensus report that lack of availability or utilization of behavioral interventions is not a sufficient justification to withhold medications for opioid use disorder. So we should no longer see this model where patients are required to attend counseling in order to get their life-saving medication. Just to end with sort of philosophy of care and how we think about approaching patients, our patients with opioid use disorder historically have faced stigma, discrimination, and bias at every turn in the healthcare system. And so addressing that discrimination and thinking critically about the way we as individuals and the way our systems really impact and prevent people from being able to access dignified and equitable care is really important. I often sort of think of these key questions of first, would we respond this way to another patient? If, this patient said had CHF or diabetes and there was an unexpected lab finding, or they wanted to leave the hospital unit to go down to the cafeteria, would we be treating them the way that we're treating this person with an opioid use disorder? Two, are there ways in which our approaches and policies are actually the mediators of harm? We talk a lot about the harms of drugs, but actually a lot of the drug-related harms that people experience are because of our drug policy or our approaches, not because of the substance in and of itself. And then lastly and importantly, what is the person's most pressing need? It doesn't matter at all why we think someone should stop using opioids. The only thing that matters is if the person thinks that their life will get better in some way, if they have needs and goals that we identify that we can support and partner with them around. So to end, when we think about a systems-based checklist to treating opioid use disorder and addressing the overdose crisis, I think of kind of the three buckets of prevention, treatment, and harm reduction. On the prevention side, certainly thoughtful and judicious opioid prescribing is necessary, but probably the more important and difficult work is addressing risk factors for opioid use disorder in the first place, and then implementing screening and early detection and intervention. For treatment, we have to have access to all types of medication in all settings, and to lower the barriers, get rid of counseling requirements, and really work on reducing stigma and discrimination. And then we can't talk about treatment without talking about harm reduction as an integral part of that, making sure patients have naloxone, access to syringe service programs and sterile injection equipment, supervised consumption sites, which we know reduce fatality from overdose, and then ultimately thinking about a safe supply. So with that, I will thank you, and we are right on time. My references are on the next slide, and I appreciate everyone's attention.
Wow, that was great. 8 seconds to go. I think I'm going to cheat a little on the timing and and if you don't mind, ask a question. There have been some really wonderful questions that have come in. And I'm trying to pick one that I think All right, here's a good one. Somebody's asking what the goals are for opioid treatments, and they're saying, should somebody be back to a normal life? Should they be returning to work? How do you think about setting goals with your patients with medication-assisted treatment?
Yes, I love having it be goals based, and the goal should be the patient's goals, not our goals, importantly, much like with any other care. So my question would be to the patient, like, what do they want to see their lives like? If they, I often say, if you could wave a magic wand and have your life look differently a year from now, what would that look like to you? And for some people, that's going back to work. For some people, that's parenting. For some people, that's staying out of the hospital and staying medically healthy. For other people, it's, having a more meaningful relationship with their partner or their parents. So I think figuring out what those goals are and really thinking about patient goal-directed therapy as being the way that we assess whether treatment's working or not. And then the question is not that a person is failing treatment, but that the treatment is failing the patient. So if someone's not meeting their goals, much like we would switch to a different antibiotic or a different chemotherapy agent, if someone's illness was still not in remission, if someone is not getting to where they hope to go and they're still symptomatic, then we need to think about changing the treatment plan, not blaming the patient.
Excellent. Thank you so much. And I know there are many other questions, so we'll try to get to those in our after questions. I also think that going back to Sarah's slides will answer a lot of the questions that have come up. And again, really appreciate your time this morning and thoughtfulness on how to take care of people with a really challenging disorder who really can get better. So
Thank you, Lori.